exposure prophylaxis, also known as PrEP. I also wanted to extend an acknowledgement that one of my colleagues here, Dr. Jared Baton, contributed some of the material that I'll be sharing with you today. He's actually one of the lead researchers on this topic. Now, HIV pre-exposure prophylaxis is a concept that, sorry. All right, let's try it. There we go. Oh, I have no relevant financial disclosures.
You know, I have that. All right, well, I like it. I'll use it for everything.
Please remember to put your microphones on mute as we're hearing some of your conversations. Thank you.
Okay, these are our learning objectives. Hopefully by the end of this session, you'll be able to summarize the evidence supporting PrEP as an effective HIV prevention strategy, understand the importance of adherence to PrEP for effective HIV prevention, and be able to review basic prescribing information related to the use of PrEP. The concept behind pre-exposure prophylaxis for HIV is really not new. The idea is you administer medications that are typically used to treat HIV, but administer them to someone who does not yet have HIV, but is at risk for contracting HIV. And in that way, taking the medication actually helps to prevent and substantially reduce the risk of acquiring HIV infection. So, for example, we do this frequently with malaria. Travelers going to a malaria endemic region, we often advise them to take a medication every day that is ordinarily used to treat malaria, but in this case, we're using it to prevent malaria, and it can be very effective in that regard. Now, in the Caribbean region, this is not a very clearly established procedure and resource. However, I thought it would be valuable to discuss it today because I do think it is coming to the region. And in fact, in some ways, okay, I'm sorry, having a hard time talking over. You may already be seeing clients of yours who are taking pre-exposure prophylaxis or may have questions about it. So I think it's valuable to at least understand what the principles are. Okay, so there is actually quite a bit of very high quality evidence supporting the efficacy of PrEP for preventing HIV infection. I'm showing on this slide 4 high-quality randomized clinical trials that showed a statistically significant benefit in terms of using PrEP to prevent HIV infection. Each of these 4 studies used either tenofovir or a combination medication involving tenofovir plus emtricitabine. A combination tablet in the United States known as Truvada. And the 4 studies I've listed, they actually involve different populations at risk for HIV acquisition. The Partners PrEP study involved heterosexual couples who were serodiscordant, meaning one partner in this relationship had HIV, the other did not. The person in the relationship who did not have HIV was randomized to receive pre-exposure prophylaxis or placebo, and these individuals were followed over time. And what you saw, depending on which medication was used, either a 75 or a 67% reduction in the risk of HIV acquisition among those individuals who were randomized to receive the PrEP. Similarly, the TDF2 study performed in Botswana, this was not specifically among serodiscordant couples, but did involve heterosexuals, men and women who were at high risk based on their sexual behaviors of acquiring HIV. That study showed a 62% reduction in the risk in those who received PrEP. The BTS study performed in Thailand involved injection drug users. In that study, they saw a 49% reduction in risk. And then the IPREX study involving men who have sex with men, performed in multiple countries, showed a 44% reduction in the risk. So again, 4 high-quality randomized clinical trials, all showing statistically significant benefit for its use. Now, I always like to quote our former Surgeon General, C. Everett Koop, who points out that drugs don't work if people don't take them. And if we look back at this slide, we do see kind of a range of efficacy with the highest efficacy of 75%, down to 44% in the IPREX trial. And it's worth asking, is the difference we see in the efficacy across these different trials potentially due to differences in adherence? And so as part of these studies, the researchers did look at adherence and were able to estimate the levels of adherence in the participants. And if we look again at this table, there is a pretty clear and consistent correlation between the level of adherence among participants and the degree of protection afforded by PrEP. And they were able to go further and really isolate and focus on just those individuals in the trials who clearly had high adherence, either based on measurement of drug levels in their serum or pill counts. And we're able to establish that among those individuals who really had very good adherence, the protection rates for PrEP were, somewhere between 70 and 92%. So those individuals who can take it every day as prescribed enjoy a very high level of protection from PrEP. Not perfect, but nevertheless really quite high. And it's also worth mentioning there were a couple of negative trials, specifically the FemPrep and VOICE trials, that did not show a benefit for PrEP. And as it turns out, the adherence levels among those participants was extremely poor. Less than 30% of participants in those trials appeared to have been taking the medications. And that is presumably why the study failed to show a benefit from the PrEP. Now, it's worth asking, well, how safe is this? And as far as we can tell, it is quite safe. In the trials that have been performed, the adverse effects were seen in only a minority of subjects, and those effects were generally mild. GI effects being the most common, but only occurring in less than 10% of participants, typically only during the first month only. So like many side effects, over time, the body sort of gets acclimated to the new medication and those side effects wane. Specifically with respect to tenofovir, one of the component medications used in pre-exposure prophylaxis, there have been some concerns about reductions in bone mineral density or in renal function. The changes they've seen in the studies, both in the clinical trials and in follow-up cohort studies, have found very minimal problems in that regard, and frankly, not clinically significant. So as far as we can tell, this looks like a very safe intervention. Now, another question worth asking is, if we administer pre-exposure prophylaxis, will this lead to a reduction in safe sex practices? And in fact, will we start to see more problematic high-risk sexual behavior because patients who receive PrEP now feel that they're no longer vulnerable to HIV infection? It's a valid question. In the trials performed to date, this study was looked at, and they did not see any so-called risk decompensation as a consequence of being on PrEP. In fact, what they saw in the clinical trials was that unprotected sex new sexually transmitted infections actually decreased over time in patients who are enrolled in these studies, possibly as a consequence of the ongoing risk reduction counseling that should be provided at each and every visit in patients receiving pre-exposure prophylaxis. Now, what happens in clinical trials doesn't always play out in the real world. Nevertheless, I guess the data we have from these clinical trials suggests that increased sexual risky behavior has not been associated with administering pre-exposure prophylaxis. So this slide sort of nicely summarizes how PrEP is recommended and administered here in the United States. You consider PrEP for patients who are at substantial risk of acquiring HIV infection. And substantial risk varies a bit according to the population in question, and it can be a bit of a judgment call, but I think these are helpful guidance for that. Among men who have sex with men, clearly serodiscordant relationships, history of sexually transmitted infections, high number of sex partners, inconsistent condom use, or commercial sex workers. These would indicate an individual at substantial risk of acquiring HIV and for whom PrEP could at least be considered. Among heterosexuals, relatively similar guidance, serodiscordant relationships, history of STDs, inconsistent condom use, commercial sex work. These would render someone as being potentially suitable for PrEP. And then injection drug users are clearly at risk of HIV infection if they share needles and or do not have access to a clean needle supply. Now, the next step is thinking about who would be clinically eligible. Well, it's critical to ensure that any person to whom we're considering PrEP be confirmed that he or she does not have HIV infection already. So one has to perform HIV testing before prescribing PrEP and ensure that the result is negative. One should ask about signs and symptoms of acute HIV infection and defer pre-exposure prophylaxis for any patient in whom you have any suspicion that they might have very recently acquired HIV infection. These patients should have normal renal function. Drug interactions are very rare, but should be considered. And we want to know about the hepatitis B status of a patient in whom we're considering PrEP. The reason for that is that the medications we use for PrEP are also active against hepatitis B. And so it's important to know if your patient has chronic hepatitis B infection or not right from the start. The way it's prescribed is recommended is daily, once daily dosing every single day, but only prescribe less than a 90-day supply at a time, because these patients really should be checking in at least every 3 months for testing for STDs, testing for HIV, periodic checking of renal function, and counseling regarding sexual risk behavior. And the additional testing that might be done will sort of depend on the population in question. There is a valid question about the use of pre-exposure prophylaxis among serodiscordant couples who desire pregnancy. I think it's a reasonable concept. We don't have a whole lot of data around this issue, other than to say that the medication used for PrEP, the tenofovir and the M-tricytidine, do appear to be safe in pregnancy and are used routinely in women who are pregnant or who may very well become pregnant. So just to sort of wrap up and summarize our key points, in terms of the evidence, pre-exposure prophylaxis has been proven to prevent HIV acquisition in diverse populations of people at high risk for HIV acquisition. At least in the United States, it is approved in combination with counseling around safe sex practices for HIV prevention. Adherence is critical, and the level of protection afforded by PrEP is proportional to the degree of adherence among its recipients. And then we covered the basic prescribing information, at least as how it's recommended here in the United States. So I'll conclude there and open it up to any questions or comments you may have.
Thank you, Dr. Behrens.